You know, for 2 solid centuries, there's been one substance that has really defined our entire fight against pain. It's the original, it's the benchmark, it's the gold standard. So today, we're going to unlock the science behind morphine.
Okay, let's start at the very beginning. Way back in 1806, a German pharmacist, Friedrich Serturner, pulled off something incredible. He isolated the active ingredient from opium, and what did he call it? Morphine, after Morpheus, the Greek god of dreams. And I mean, what a perfect name, right? It just so perfectly captures its powerful, sleep-inducing, and of course, pain-relieving qualities.
Now, before we get into the real nitty-gritty, we have to talk about the family morphine belongs to, the opioids. And really, it's just a broad term for any substance, whether it's natural like morphine or synthetic like fentanyl, that works by grabbing onto these special opioid receptors in our body. Once it binds, it kicks off a chain reaction that, you guessed it, ultimately blocks pain signals. So what is it that gives morphine this gold standard status? I mean, why is it the one that every other painkiller gets measured against? Let's find out. Well, it all comes down to its origin. See, morphine is the main active compound that's naturally found in opium. Its unique chemical structure basically became the blueprint, the original reference point for every potent painkiller that came after it. So now, whenever a new painkiller is developed, the very first question everyone asks is, okay, but how does it stack up against morphine? All right, let's zoom way in, right down to the cellular level, and see how this thing actually works. How does this one molecule stop us from feeling pain? It's a really fascinating and incredibly precise biological process. Think of it kind of like a key fitting into a lock. First, the morphine molecule, that's our key, finds and binds perfectly to an opioid receptor on a nerve cell. This opens up a channel, letting potassium ions rush out of the cell. That causes the cell to hyperpolarize, which is just a fancy way of saying it makes it less likely to fire an electrical signal. And the end result? It stops the release of neurotransmitters, like substance P, that are screaming pain to your brain. The message is basically blocked before it even gets sent. Okay, so what's really interesting here is that not all of these opioid receptors are created equal. Morphine mostly targets the mu receptors, and yeah, these are the ones responsible for that powerful pain relief and even the feeling of euphoria. But, and believe me, this is a huge but, they're also responsible for the most dangerous side effects like respiratory depression and physical dependence. On the other hand, you've got kappa receptors. They also help with pain relief, but with way fewer of those risky effects. This difference, this is basically the holy grail for drug developers, right? The quest to create a painkiller that only hits the good receptors, giving you all the pain relief with none of the dangerous baggage. So understanding the mechanism is one thing, but actually using it in a hospital or a clinic, that's a whole different ballgame. Getting the dose just right is this incredibly delicate balancing act between giving enough pain relief and avoiding those really dangerous side effects. And this is where you can see morphine's incredible versatility. Look at all these options. Depending on the situation, we could be talking post-op pain or chronic illness. It can be given in so many different ways, and each one has a different speed and a different duration of action.
Let's talk about some actual numbers here. So for an intramuscular injection, a pretty standard dose is about 0.1 to 0.2 milligrams for every kilogram of body weight. But when it's given intravenously, where you need an immediate and really carefully controlled effect, it's given in these tiny 1 to 2 milligram doses, slowly increased until the pain is under control.
But now, check this out. What happens when you deliver the drug much closer to where the pain signals start, in the spinal cord? For an epidural, where morphine is injected right into the space around the spinal cord, the dose you need drops dramatically. We're talking just 10% of the intravenous dose. And then, if you go one step further and give it intrathecally, which is directly into the spinal fluid itself, the dose you need is an incredibly tiny 1% of the IV dose. It just goes to show you how unbelievably potent this drug is when you deliver it right to the central nervous system. But of course, all of that power comes with a dark side. The very same mechanism that's so good at silencing pain can also wreak havoc on the body's other essential functions. Yeah, the side effects are really a full-body affair. In your brain, it can cause anything from drowsiness to agitation. It can slow down your heart, and famously, it brings your entire digestive system to a screeching halt. So this is absolutely crucial. Of all the potential side effects, one of them stands way out as the most dangerous and life-threatening. Those same mu receptors that give us pain relief also send a message to the breathing centers in your brainstem, telling them to slow down. In an overdose, breathing can slow down so much that it stops altogether. And then you have the cruel irony of dependence. The body gets so used to having the drug around that when it's suddenly taken away, everything flips into reverse. The euphoria becomes depression and despair. The relaxation and calm turn into agitation and restlessness. It's like your body is literally screaming for the very thing that caused the problem in the first place. So, after looking at the science, the dosing, the side effects, where does that leave us? What's the big picture here? How should we think about this drug? Ultimately, morphine is a total paradox. On the one hand, it's an absolutely indispensable tool for managing severe pain. It's a gift to medicine that has relieved just an untold amount of suffering. But that incredible power is forever tied to these profound, inherent risks. And that leaves us with the central question that clinicians and patients have to face every single day. How do we balance the gift of a dreamlike escape from pain, inspired by Morpheus himself, with the very, very real risk of its most dangerous nightmares?